my pleasure to introduce our guest today, Ainsley, who neither of us can remember how or when we first met, but surely it was a very long time ago. Ainsley is, as you can see from her slides, currently a professor of bioethics at the Sydney Health Ethics group at the University of Sydney, and she's been there for about a dozen years, I think now. She originally did her doctoral training in bioethics at Melbourne, and then spent some time at Imperial College in London and the University of Bristol in the UK, and then moved back to Australia, where I think you're from originally. Yeah. We've known each other because the bulk of her work is around genetics and genomics and ethics. So she has a ton of funded grants in Australia around things like reproductive genetics testing, which I think is going to be a lot of what you hear today, carrier testing, and something called Mackenzie's Mission, which is this huge carrier screening program that Australia has been really very novel in the work that they're doing there. And then also around like mitochondrial replacement therapies and data governance, and I could go on, but most importantly, Ainsley is brilliant and one of the kindest and most collaborative researchers I've ever worked with. So it's really a pleasure to have her here with our group.
Thank you, Kelly, for that wonderful introduction. Glad it got recorded so I can listen to it. And thank you for the invitation. And it's a pleasure to be here in your very beautiful centre, which I took photos of earlier to send back to my colleague so they can all be jealous of me. So so as Kelly said, my name is Ainsley. I'm from the University of Sydney and I'm working in bioethics. And today I'm going to tell you about a project that we're coming to the end of, which was around the notion of reproductive autonomy, but really around the use of genomic information in reproduction, and most specifically in pregnancy. And so I'm going to dive in. So if I can change my slides. So before I go anywhere, I just want to start by acknowledging my team who are part of this project. You might recognize some or most of the names on this list. It was a stellar team of interdisciplinary experts and a lot of fun to do this project as well. And as we go through each element of the project, I've highlighted just a few of the people whose work was particularly material to that bit. So this is what I'm going to tell you about in the project. I'll just give you the motivation for the project to start with, like how and why the project came about. And then the project had three arms, which have happened really somewhat in parallel, but the qualitative aspect happened before the deliberative aspect. But what we wanted to do was some theoretical work around what reproductive autonomy is and could be, and kind of some limits with it at the moment, how we would change it if we could. Then we wanted to talk to health professionals around how they experience reproductive autonomy in practice and what they appreciate and what they find challenging. And then we wanted to speak with people who'd had children recently. And we did that using a method that Professor Jackie Leach-Scully has pioneered called dialogue groups. And it's kind of partway between sort of a formal deliberative citizens jury and a focus group. So I'll tell you a bit about that. And then kind of where do we land, which we're starting to think about quite a lot at the moment because the project is in its final year. So to tell you a bit about how and why this project came about. So Target, I have my colleague, Dr. Catherine McKay, to thank for the acronym. And I think it's a really nice imagery because we talk about targeted testing and expanded testing, but what it means for our project is theories of autonomy in reproductive genomic testing. So thank you to Kate for that insightful acronym. And it was motivated, I wrote this grant, it took me a couple of goes to get it. I think it's always really good to be authentic and transparent about funding. We obtained the funding for this grant back in, I think it was 2019. I remember hearing I was successful in about November 2019. And I was so surprised that I wrote back to my research office and said, "You're joking." And apparently the officer was so shocked by my reaction, she actually went and double checked to make sure that we were actually successful, because it was a scheme that has a low success rate. But the motivation was, I work in an environment where you see, we have an environment for healthcare in Australia that is a hybrid healthcare system where we have some public funded availability of testing and screening, and then we have things in the private sector. But tests like non-invasive prenatal testing in Australia or non-invasive prenatal screening are almost entirely offered by commercial entities. There's no formal screening program in pregnancy in Australia. And so NIPT as an example of a technology for testing in pregnancy has just been rolled out in a very laissez-faire way. And what we were starting to see was even just friends saying, I had the most terrible experience with NIPT. It gave me something that just plunged me into uncertainty, and actually it really didn't help me make a decision in my pregnancy about what to do. And this was just one example, but what I was observing was, and I'm not the only one obviously, but I was observing just an increased an increased use of genetic information, a creep in the scope from a very tightly focused range of things to potentially look forward to a little bit more. Why don't we just add this? Why don't we add this? Why don't we add this? And this was generally being talked about as an enhancement or expansion of autonomy. It's being talked about as an expansion because we're giving people more options, we're giving people choice. And that troubled me. I was kind of like, but wouldn't the opposite also potentially be true? In that if we are offering increased options and increased technology in reproduction, could that not also mean that somehow choice is being constrained because the imperative to take up the technology is there? And all of this is happening on a background of being a risk society. You know, we talk a lot about risk in pregnancy, we talk about risk management. And also we are very just innately as humans geared towards wanting to seek certainty, we seek information to inform our decisions. We're also a society that tends to believe in the power of testing. So it is quite hard to kind of come to grips with the notion that a health professional offers you a test and that test might not actually help you. We're very geared towards testing being a good thing, and the only thing that we should do is more testing. So we have that happening on a background of innovation in prenatal testing, lots more ways that we can obtain information about a fetus or obtain information to inform a couple prior to pregnancy. And also the cost of doing this is much less than it was in the past. So all of this is just heading towards increased use of genomic testing. Now, there's a variety of issues that arise from this. Not all of them are relevant to this project, but I just want to highlight that, you know, this is happening against a background of wide ethical consideration about testing in pregnancy. But this kind of increase of genomics in reproduction was something that was really of interest to our group. And as I've already said, this expansion of prenatal genomic testing could actually constrain autonomy. And if that's the case, well, you know, how should we respond to that? What should we do? So this is where our project came about. It was funded by the Australian Research Council, and we actually delayed a year because of what happened to the world in 2020. And our aim of the project is to generate a better model of reproductive autonomy, one that is more appropriate for the genomic age. I don't know that we have that model yet, that's my spoiler alert, but so I'd really love your feedback on how to tie the various elements of this project together. And we'll be running a workshop towards the end of this year that actually tries to wrap that up in a bit more detail. We have, as I've said already, 3 different methods. We did some theoretical and normative research, which is coming towards the end now. We did qualitative interviews with health professionals, and we did deliberative public engagement with parents, or a dialogue groups with parents. So I'll now move on to talk about the theoretical component of the project, which has been undertaken by way of a PhD project with Isabella Holmes, and Isabella, or Belle, is supervised by myself and my colleague, Dr. Catherine or Kay. So we went from the starting point of a definition of reproductive autonomy that was just extremely high level. Obviously, this is a topic that a lot has been written about over the years. And so very broadly, we describe reproductive autonomy as an ability to reflect critically on values and your desires and your preferences, and to use these values, desires, and preferences when you make a decision, either before pregnancy or during pregnancy. We recognise, of course, that this concept can be quite vague. It's often used without really being clear about what is meant. It's also used as a universal good, like it's used in the opposite of a pejorative way. It's used as quite a positive term, as something to aim for. And as I've talked about a little bit already, the challenge here is to encapsulate the complexity of this while also trying to conceptualize it in a way that might be useful in practice. And we have this challenge of the increased offer and increased uptake of testing and screening in reproduction. And so how can we be sure that people have the time and space that they need to make a decision that is consistent with their values, when we don't even really allow people the time to work out what their values are. The information that we're presenting them is often quite reflective of, say, a clinical framing, and people find it hard to really imagine what it might be like to parent a child with a particular condition, or even to have that condition themselves. So the other thing that happens is that reproductive decisions aren't made, completely on an island somewhere with no influence. So reproduction is inherently socially embedded, and people, expectant parents, or whether a person is pregnant, I might use the term person and woman interchangeably throughout this presentation. We've had a lot of actually quite reflexive discussions in our team about terminology, and it's an area of really significant debate in Australia at the moment. But however one identifies, you are socially embedded when you are making a decision about reproduction and making a decision about whether to accept an offer of genomic testing. And there is a lot of discussion around so-called responsible parenting, and I think there is a valid criticism here around pressure to be a good parent, to be a responsible parent. And you hear anecdotal things like people coming up in the street to a parent of a child who has Down syndrome, and the person saying, "Oh, I'm so sorry," or things like that. So we have this kind of inherent approach to disability and difference in society that often sees it as a tragedy or a sad outcome, or something that, why didn't you do something about it when you perhaps could have? And then alongside of that, we have the technological imperative that comes from genomic testing. And that testing is often offered in a condition of imbalanced power. And I don't mean that necessarily in a pejorative way, just a descriptive way, in that you have a professional who holds a whole lot of knowledge, and then you have a person who will have a very specific embodied knowledge from their experience as a person in the world, and perhaps from previous pregnancy. But for a lot of the time, they're making these kinds of decisions for the first time. And they might be doing that without ever having known a person that has a particular kind of disability. And we are often inherently kind of, through our social structures, kind of taking on beliefs that disability is something that is not necessarily good and should be avoided if at all possible. So in this, we are offering these tests in the name of autonomy. And we tend to, at least in the clinical sphere, take autonomy to kind of enable consent or inform consent. And we do that on a fairly liberal conception of autonomy, which is one that takes a fairly individualistic approach. And it's quite helpful for a straightforward medical procedure. You provide the information, you make sure a person is not being coerced, you make sure they have capacity to make a decision, and you go ahead. Pregnancy is quite complex. I don't want to necessarily argue that pregnancy is exceptional, but it is certainly a very complex area of health. And the problem with autonomy is that if it becomes almost conflated with informed consent, then we end up with an information, capacity, voluntariness, go type thing, and it can happen in a fairly constricted time frame. And quite often when it comes to testing, what we do to help people make decisions is we give them a leaflet, or we give them information, they go away, they automatically digest all of that, and they make their decision. And the information that we give them can be quite voluminous, and it can also be very often about the test, like what the test will involve. Quite often, less often, it's about what the test may find. And very rarely it's about what it's actually like to be a person in the world with the conditions being tested for. And very rarely does it prompt someone to think, what might I do if I receive this information? Why am I having this test in the first place? So some of the problems that we've used as a kind of a basis for, Belle has used in her thesis, is the social embeddedness, the routinization of testing, and the fact that you can kind of have one test which leads to something else, which leads to something else. And pregnancy as a result ends up increasingly monitored. And what this is doing is sort of taking this slightly more medico-legal conception of autonomy, and what we want to do is better align it with a more rich notion of autonomy that comes from philosophy. And a big motivator for us has been trying to unpack this distinction between data, information, knowledge, and wisdom. And what we obviously want is for people undergoing reproductive decision-making to arrive at wisdom, but often what we're only giving people is data or information. We're not really enabling people to get to that knowledge and wisdom stage. So we make 4 suggestions around how the theory of reproductive autonomy can be improved. And that involves the things that are written on the slide here: relationality, substantivism, providing adequate options, and then reinstating certain conditions that are both internal and external, and kind of being between the two. I'll just go through each of these very briefly. So what we're doing when we're arguing for relationality is unsurprisingly drawing on theories of relational autonomy. So rejecting that very liberal individualistic notion of autonomy and saying that we are inherently social people, we are making our decisions in a social context. And what we need to do is take this relationality as foundational and reclaim autonomy as this emancipatory concept. And we need that relational account in autonomy to account for this more unique state of pregnancy, because we are so influenced in how we make decisions that having a simple kind of tethered information, voluntariness, decision type approach is just not going to really recognise what it's actually like. With respect to substantivism, we're not just looking at the process of the decision, we're looking at the content of the decision as well. And Bell is arguing in her thesis for a weak substantivist account. And so this is things like paying attention to social norms, the social context that I talked about earlier, and sort of noting and paying attention to how certain choices are encouraged or discouraged, either implicitly or explicitly. So we need to think about the medical social pressures and expectations on pregnant women and people. And if it is a procedural account of autonomy, that's kind of neutral to the content, but we are really interested into what is the content of that decision and what is influencing it as well. And then we argue that both internal and external conditions for autonomy are important. And generally in a lot of the literature about autonomy, it only really looks at internalist conditions, but we're also interested in externalist conditions, and we're sort of getting to a point that pays attention to both. So for example, trying to motivate that attention to reflect on your core values. And so we have to have external conditions as well. So an important internal condition might be coherence between your higher order values and your reproductive decisions. And an external condition might be that healthcare providers are creating an environment where you can have genuine separate options presented to a person making a decision rather than a particular path. So both of these are important for autonomy. And then finally, you need an adequate range of options to choose between, and here Belle is drawing on rising perfectionism. And there is a lot of discussion about choice. And what we are arguing in this work is that actually we need to choose between an adequate range of different options. And you need more than one option that actually matches your pre-existing values. So move away from emphasis on mere choice towards this more full understanding of reproductive autonomy that looks at choice between reasonable options as well. So relationality, substantivism, internal and external conditions, and an adequate range of options. And that's Bell's thesis in 15 minutes. Okay, so we also talked with health professionals, and my colleague Karen Drysdale led this work. So we undertook 25 semi-structured interviews with a variety of professionals that look after people during reproduction. So genetic counsellors, midwives, GPs, fetal medicine specialists and obstetricians. And we undertook somatic analysis using broadly Brown and Clark, but Karen is an extremely experienced qualitative researcher. So there is a little bit of Karen magic in there as well. And we had kind of 2 key questions that we asked them. How do they understand reproductive autonomy? We wanted to know how they sort of approached it and defined it. We also wanted to know what they felt facilitated or blocked autonomy in practice. And also, it's 3 questions, and also what they felt about the expanded use of genomic testing in pregnancy. And we had a few key things that we identified in this work. There was a lot of discussion about what these professionals believed that pregnant people wanted. And there was a key tension that we identified between the fact that people who are pregnant want information, but they presumed that that information was going to be beneficial. And they also wanted reassurance. And wanting to be reassured and wanting beneficial information were in tension with each other because, of course, the information that you get doesn't always offer that reassurance. And they also talked a lot about this information becoming ubiquitous in pregnancy and the fact that the technology is moving really quickly, but actually the resources to support the decisions that need to be made after its receipt are lacking. And so there was a lot of kind of concern about the fact that people are kind of being left on their own to make pretty significant decisions. And they recognised, as we suspected, that too much or uncertain information might actually have an autonomy constraining effect. And so one of the professionals we spoke to sort of talked about how we were entering a wormhole about what's going to happen next. And so they also talked about this significance creep of this information to have a very particular salience in reproduction and potentially a disproportionate salience in reproduction. So here are some things that our participants said. So one, they talked about it's moving really fast. The testing's available, it's just becoming just wanted because it's there, so it's wanted. And it's also wanted by providers. Obstetricians mention it, more and more complex tests like exomes, and the mentioning of the test means that people want it, which means that it goes faster. So it's kind of a self-fulfilling prophecy. A general practitioner, because there's a lot of prenatal care in Australia is provided by primary care physicians. This was a discussion about whether a person can actually make an autonomous decision. And this person said they probably don't have full autonomy because it's really complex. From the medical side, I don't feel like I grasp it, and then I have to explain it. And if you've seen an antenatal appointment, it's about 2 minutes that we talk about this. So, you know, lots and lots of complexity in a very constrained time frame. And a maternal fetal medicine specialist said autonomy is really difficult because you put the whole onus back onto the patient and they may not have what they need, the tools to understand or acknowledge what it means. And then an obstetrician said, what are we going to do? So you're going to be full genome testing, guaranteed. None of this trisomy 18, 21, 13 rubbish. It's going to be like the full gamut. And our scientists are amazing. The science is amazing. What the hell? How do we implement it? How do we hold so much more grey zone, right? Like they got quite like emotional and really, really invested in the topic. And so, you know, we could see their kind of frustration, but, you know, their passion and hope for this technology as well. And so I won't present too much more of the analysis of this because we have published this already, came out in New Genetics and Society last year. And I realised tragically afterwards, this particular journal is only very ad hoc indexed in PubMed, so you will not find this paper if you search in PubMed, but it is there and it is open access, so please take a read. And it was qualitative interviews intermixed with some theoretical normative reflection about what we found. Okay, this next section is under draft. We haven't got the paper quite ready yet, despite everybody's good intentions. We're on the way. And this is reporting dialogue groups, which we held just about a year ago, around about this time last year. So this is about parents. So as I mentioned, we did the dialogue group methodology, which Jackie Scully pioneered. She's used it to talk about a variety of technologies in the past, including sex selection. But we wanted to get parents talking with each other about reproductive autonomy and genomic testing now and in the future. We wanted to talk about how they found it, and we wanted to present them a scenario to see how they felt about it. We talked to people in 2 major cities in Australia and also in regional cities because we have quite a dispersed population in Australia. We're very spread out. And we had around 8 to 9 participants per group, and that is good for this particular methodology because you don't want it to be so big that people feel overwhelmed and unable to talk, and you don't want it to be too small that you're getting kind of an echo chamber. And we wanted anyone who had a baby within about the last 2 years, but not within the last 6 months. And that was just only because we sort of wanted them to have a bit of distance and have a bit of time to reflect. We were able to recruit people with diverse socioeconomic status, diverse education, and diverse ethnicity, which we were really happy about. And this is the scenario. So because we're Australian, our character was called Kylie. And Kylie had non-invasive prenatal testing in pregnancy, and then we branched the scenario. She either had a low chance result, That is, her result did not detect any trisomy or anything else for that matter. And then because Australia tends to automatically offer other kind of things, it sort of offers as an opt-in basis some other opportunities to find conditions as well. We had a scenario where she was given a high chance result for Turner syndrome, and which is a syndrome that is compatible with life. Generally, people with Turner syndrome are presented as female, and they tend to be infertile, and they tend to have quite short stature, I think, although Kelly can correct me if I'm wrong on that. We did know it at the time, and we had a genetic counsellor as part of our research team as well. Also there to help any parents that needed to reflect during the scenario as well. As a result of that, we branched the scenario to no further testing or to amniocentesis. And as a result of that, it was either that Turner syndrome was confirmed or that Turner syndrome was not identified, but a variant of uncertain significance was found. So you can see what we were trying to do here in this scenario. We were trying to provide a variety of results to identify some of the ways that this testing could manifest. And we also then at the end wanted to talk to them about the future expansion of testing and get their opinions about it. And it was a very free-flowing discussion. It was facilitated by Jackie. I'm not sure if any of you have ever seen her in action, but she is a master and just so great at getting participants to reflect on their values, to prompt them gently when required. And it was wonderful to observe in practice. And we transcribed the recording, we recorded them and transcribed them and analysed what we saw. And so what I'll present here is kind of how parents talked about their pregnancies. So huge demarcation between regional and city people. So if you live in the regions, they were like, we can barely get an appointment, let alone get testing. It's very expensive because our public clinics are so overwhelmed, we have to pay privately. We get offered a 12-week scan at 19 weeks, etc. But what was also super interesting was that some just got told to have testing. And then there were at least a few participants who had never heard of any type of test in pregnancy until they came to our dialogue group, probably because of their age. We had some quite young participants. They were really keen to know about testing. They were information seekers, but they found it really hard to get trustworthy information about testing. And they all talked about how stressful they found reproduction. And there was this sense that they couldn't talk to people older than them because they were the first generation. And I guess that's true of every generation, but they said it's really technical now and we're needing things that no one else has before. And so that's kind of some of the things that came out about their experience. Despite how stressful they found it, they wanted everything. They wanted all information that they could possibly get their hands on, even if it was uncertain or even if it was about a large number of conditions. And the only real mediator to limit that was how much the test costs and whether the test posed a risk to the pregnancy. And they saw the testing as very empowering and reassuring and stress reducing. But at the same time, they tended to assume that the information would be interpretable and unambiguous. But in each group that we held, there was usually one person who had had a prior pregnancy or had in this pregnancy received ambiguous information. And they were the voice in the room kind of saying, hang on, and kind of talking and reflecting about the fact that there was one person in particular that I can remember who said, because of what happened in my first pregnancy, they'd had 2 pregnancies, and they said, I declined all testing in my second pregnancy because of what happened to me in my first pregnancy. And that, the room, I think most people who came into the room left the room with pretty much the same opinion that they came in with, but it enabled the discussion to be quite nuanced. But many of the people in the room came having done lots of their own research as well. So here are some quotes from some of the groups. This participant said, it's like car insurance. If you can't afford car insurance, can you afford to drive? I would rather spend the money that I need to now with prenatal testing because it gives me peace of mind. I can sleep easy. This person says that testing sometimes goes a bit far. There's still things that can go wrong once your perfectly healthy fetus has become a live baby. You can never completely rule out that you're going to have a perfectly healthy baby. And then this participant said, I personally think more information is better, but obviously when you've gone through the experience before and it's added stress, it gives you a different look. I want to know as much as I can because I don't know as much right now, and so I think everything helps. But for future pregnancy and onwards, I don't know if I have that mindset. So I think they're talking about their slightly ambiguous experience. It's very much about that experience the first time around. So I think it really shows this kind of distinction between first and subsequent pregnancies and how that lived experience can change. But the other thing that was really challenging was this expansion of testing, and I think it's a really interesting epistemic challenge. So we, at the end of the scenario involving Kylie, we kind of went off and said, okay, so Kylie had a pretty focused test. Now we could potentially find out a lot more. And Jackie obviously explained it in slightly more detail on that. But they wanted everything. They wanted, even if the information had low predictive value or was not actionable, they wanted to know all of it now. They found it really challenging to grasp the scale and complexity of the information that this testing could give rise to. And so it's this epistemic challenge of grasping what the information will actually consist of. So this person said, I want as much information as possible so I can make a decision. I don't want to make a rash decision and not have enough information and then regret that choice. They were very much worried about not knowing something that they might have been able to know and then having something happen that they wish they'd known about. So we all go in blind. You don't know what you're getting into. And then this participant said, I'll take as many tests as I possibly can just to avoid any further stress, because stress is lingering around and it's always on your mind. So you can see here this kind of sense of wanting to do the right thing, wanting to get information, wanting not to regret the choices they made, but at the same time kind of understanding that there's a tension here around what this might give rise to. So drawing it all together, where do we land? So there is this inherent tension in reproductive autonomy. I think there's a tension theoretically in what I talked about early on, in that largely in the clinical literature, autonomy gets talked about often without really defining what we mean, or if we do define it, we tend to use an approach that's kind of quite embedded around informed consent with a pretty liberal procedural way of thinking about it. And then, but also how we actually operationalize it in practice. We've heard from professionals that they're very worried that their patients don't have what they need. We've heard from patients that they don't know where to find it. And we've heard how hard it is because of all the constraints around commercial implementation, constraints around time. And we know, though, that everybody values information, but that information may not always be valuable. And we know that people want to use it to reduce stress, but it might not always. So there is this significant desire for control and knowledge, but the information might not give rise to it. And all of this on a background that we're all encultured to believe that testing is great and we should have more of it. And it's really hard to grasp what this might look like when it's broad information. And there's not really a comparator, because in pregnancy, at least, we haven't really had anything like this. Although I think there is a parallel, I guess, in higher resolution ultrasound, for example. And this is all against a background of difficulties imposed by resourcing, social determinants of health, and patriarchal determinants of health. I'll throw that in there right at the end. So some of the social determinants are things like, the power of information, the responsibility, that social embeddedness of reproduction that I talked about, and that people can't see that you can choose to have a test, but not all information. And people tend to see this as an all or nothing. And actually, in a different research project, we've done some work on benefits and harms of NIPT. And one of the members of the project team became pregnant during the study and elected to have NIPT. And she said she found it really hard to find a provider in Australia that would only tell her about trisomy 13, 18, and 21, because that was all she wanted to know about. And she even had to her GP was kind of like, oh, thanks, you're educating me about this. And so, GPs are wonderful, but they're generalists. And so when you have these really difficult nuances, it can be quite challenging to get across the nuances of the technologies. So that is our project. Thank you so much for your attention. I'd just like to acknowledge the Australian Research Council for providing our funding, and that is how you can contribute to me. Thank you.
Lots of time for questions.
Shall I attempt to stop sharing? Yeah, there I go.
That good? Yeah, and now we can see your face.
Okay, great.
And do we want light?
I was thinking it's because it's.
Yes,
same
just,
time
it's gonna be very bright for a moment.
Okay.
So be careful.
Oh, wow,
Yeah,
yes. Thank you for the warning.
that's the warning, but it will dim and it will become more normal in a moment.
Hello?
Do you want to start?
Yeah.
There's a lot in your presentation.
Thank you very much. It was a fascinating project and a fascinating excursus of a number of very interesting pillars of the project. And I wanted to focus on the normative, more foundational part. I had a couple of observations. So the first one is that I'm very fascinated about this idea of decisional parsimony in a way, that less is more in terms of autonomy, and that having more options sometimes boils down to having less autonomy. And I wanted to ask you if you can elaborate a little bit more on that in terms of how the notion of reflective autonomy that you are building, especially in that PhD dissertation, what is the argument for saying that less options might result in more autonomy? When you were speaking, I was noting down that, this reminded me of Joseph Brass, and then you said that. And I mean, Joseph Brass' idea of, let's say, having a meaningful array of options as the basis of autonomy, it's normally understood as having a sufficient amount of options, but you're sort of turning the argument the other way around, which is very interesting. And I just wanted to ask you how you argue for having more options being a potential impediment to autonomy. Then the second point, maybe I leave it for later.
Can I just add something to Alice before you?
Because I know you've written about this.
Yes,
Yeah.
so actually it was interesting because you mentioned the way you phrased the options in the Razian way was meaningful options, and you said reasonable options.
Okay.
And I thought, was that just you just said it, or do you make a difference is there a normative difference for you between reasonable options and meaningful options, which is the way to view
I
them?
don't remember the quote from Raz by heart.
But I think it is closer to meaningful.
I don't
think, but I don't remember exactly.
This
So
would possibly be, in my words, like it's possibly an Ainsley flourish rather than reflected in Isabella's thesis. And, in some ways, I wish she would, it's kind of late in Australia now, so.
we won't call her.
Yeah, I can't call her to ask, but I think what we're sort of arguing for, leaving aside, I guess, terminology, but obviously Bell has done a close reading of Raz and that is reflected, and Bell, her first degree is in philosophy, and Kate is also a philosopher, so I'm often leaving them to those discussions in their supervision meetings. But so whatever we're using is properly reflective of the text. But I think it's not so much, I think in her thesis, the way that it's played out, Bell is not necessarily focusing too much on the amount of choice. I think choice was more a motivator for troubling the notion of autonomy, in the sense that we often see expanded choice as a justification for expanding testing. And what we wanted to do was just rebut that a bit, and using ideas about autonomy, such as a sufficient range of options or a meaningful range of options, is one way to say just purely focusing on expansion of choice is a bit wrong-headed. What we want to do is actually promote meaningful choice or sufficient choice. And so it might not be so much constraining choice, but actually not just unreflectively expanding choice in the name of autonomy. So the whole notion of autonomy that we have developed, and this paper has been submitted, and actually overnight. Yesterday, we got reviewer comments back, but I haven't dared to open it yet. But it is, I think it looks like minor changes, so hopefully it will be published relatively soon. And yeah, sorry, I've lost my train of thought, but I think the argument that we're making is quite nuanced, sort of a middle ground between ultimate, unfettered expansion and no choice at all. I mean, that's of course not what we're saying. What we're trying to do is find a way through that is reflective of technological imperatives, reflective of previous kind of slightly narrow conceptions of autonomy that argue for an expansion of testing based on a fairly thin notion of autonomy. We're trying to build this more robust account using things like substantivism and the internal and external conditions, and applying ideas such as those from America. But we can send you the paper as well.
I feel like there was an earlier paper about that too.
With Lisa Dye,
Yeah.
yes. So Belle has built on that work with Lisa and as well, yeah. And we've also published with Lisa a slightly separate paper around access to information, but more in a screening context, and arguing that screening is not the place to get all the information you want to just because you can. And so we sort of, it's a slightly different argument, but that was made more in the context of reproductive carrier screening, which this project didn't deal with quite so much, not least because we were doing Mackenzie's mission at the same time. Yeah, but I feel like all my projects at the moment are very mushy. They sort of overlap with each other quite a lot. Yeah, thank you for your question.
Can I just ask something else? You had a second question, sorry.
Yeah,
so I mean, I didn't want to. So the internal and external factors that you mentioned as something that should be taken into account, and then what I wasn't sure there is taken into account by whom, because in one reading it would be these are taken into account by the individual or the providers and patients, or they have to be understood at that level. But these conditions can be also understood or taken into account by institutions or the state or whoever makes decisions about what is on offer and what can be done if things are on offer. And I think at that level, it's much more interesting, perhaps, because what you'd call external, which is, for example, the type of healthcare system you have, or other considerations in terms of income level of the country, would have something. So I just wanted to see how did you place it? Where did you place it in that?
Yeah, and that's actually the bit of the project that we're thinking about now, because what we're trying to do in this final year is bring it all together. Belle's thesis is kind of the positive theoretical case for this, and actually, when Belle presents this work, she has a little point in saying, this isn't quite ready for clinical implementation yet. And I took it out because I was like, don't apologize for your research, but as in, the substantive argument stands. But I think your point is well made, which is, how are we going to actually do this? And I think, for me at least, if our project has any impact at all, I would love it to have an impact at policy level. I think that's where we need to start. I think it would be wonderful if it can also filter down to the clinical interaction, but I think we need policy first that recognises some of the constraints that we're pointing out in our project. And then that in time, we can also, you put it in training, you put it in the materials that people use, you put it in decision aids. We have to build in a range of resources that allow people to reflect on why they're having this testing and what they hope to gain from it. But I agree with you that the institutional or policy context is the one that I think is super interesting. But some of it we may not be able to change. You can't kind of change an entire healthcare system on the basis of one test.
One last comment, and then I think others can talk, but there is another dimension of that. External. And I think that is, imagine, for example, a low, or look, I don't want to say low middle income country, but a country in which for example, living with disability is more difficult than in another country. And the way that the healthcare system works, or the living standard or whatever, is such that, you know, people with any form of disability, let's say broadly, kind of described here, will have, you know, life is much more complex and difficult than in another country with the same level of disability. Say, take Switzerland with another country. So in that case, what we often see as well is that people make choices that are different, and they are actually heavily influenced by the fact that they wouldn't have, you know, help or support or options. And that for me is an external factor, but that actually could maybe even speak for more information, because it would in fact allow those people who live in this particular setting and will, you know, have a reality that is different from what we understand, maybe make different decisions. So I wonder if it's another dimension of what we're saying, but it doesn't necessarily lead to the argument you're making. So maybe you haven't done that thinking yet, but I'm wondering whether that's something you might want to consider.
Yeah, I think it's definitely something that's worth considering. And I think it's possibly also a way that I've expressed it. I probably don't want to argue it's simply like less information is better. But what we're trying to do is argue against an uncritical notion that increased information is always the best approach. And so obviously within that, there will need to be contextual consideration, such as a person's cultural context, or their lived experience, or the history, or the way that they have ended up where they have ended up in their testing journey. So I think, yeah, definitely having access to information that enables people to make the best decision for them. And I would probably say, just instead of information, I would say support, because it's not just about information, it would be about structured support as well. In the context of a constrained health system, not all of that support might be able to be provided by a human. And we could have a separate conversation about genetic counselling chatbots and decision aids, for example. But I know in the Mackenzie's Mission Project, for example, which is a very complex test, this was a research project, Kelly mentioned it when introducing me, that was modelling what a population level offer of reproductive genetic carrier screening might look like in Australia. And it used a couple-based model. So information was returned to a reproductive unit, whether or not they were using a donor. It was not necessarily matching a social partnership. But they used a decision aid in that project, and it was really successful. And so I do think that there are opportunities to build in these kinds of things. And we have the decision aid in Australia for testing like NIPT, for example, but in all of our workshops with parents, I know it was objectively a small sample if you're talking about quantitative numbers, but no people that participated in that project had ever come across a decision aid at all. So it shows that while these really good instruments exist, they're not getting where they need to be. So I think building in some of the things you mentioned into the support that we provide to families in a way that is cognizant of who they are and where they've come from, I think is quite important. Yeah. So trying to emphasize, I guess, it's not going to be a one approach for every person.
Can I ask a question about those decision aids? I feel like most of the aids or other measures that I've seen still focus on that content, right? As you said, the testing content and maybe about the diseases, but almost never about the values.
Yeah.
And that is one of the biggest problems. Were these the same?
No, I don't think so, because they involved efforts in making them. But no, and also, I don't want to take all the credit. I'll take a tiny bit of the credit. But I think that Mackenzie's Mission decision aid is published, or at least publicly available. And the whole point of it was to help with values clarification, as I recall. And so it's not just, it was, I think the wording that was used with participants was to help you decide if this is the right test for you. That was kind of the motivation. And it was spearheaded by people such as Jane Halliday in Victoria, who's very experienced. And so I would like to think that our aid was a good one. And I think the one that exists in Australia for NIPT, which was produced out of the same place, is also a good quality one. But your point is important, which is if you're going to have a decision aid, let's make it about values clarification and about tolerance of difference and about thinking about attitudes to chance and risk, and but also paired with access to balanced information about conditions and what it's like. So and getting people to really prompt themselves to think, why am I having this test? What is it for? Rather than this is what the test involves, which I think is a very common way to approach discussion about a test.
Most people start with that and then they feel proud of themselves if they get to the balanced content, but they never make the jump to the values and then bring it back to the actions or the choice. So,
Definitely. And in 2 minutes as well. Especially because you tend to only see a genetic counsellor if you've had a high chance result or an increased chance result. And so the actual should you have this test in the first place type question comes via a GP. And as we saw in that quote, it's 2 minutes. So it's very hard to have this type of conversation in that time frame.
I also have a question about the notion of autonomy that you talked about. So, I mean, you elaborated a lot on these different components that need to be in place. But then I remember on that one slide, you had this tiny trajectory going from data to what you call wisdom, which then you said is not a straightforward trajectory from testing to wisdom. But I found this distinction, the conceptual distinction between knowledge and wisdom, very interesting that you made. And I was just wondering, first of all, how that concept of wisdom relates to what you have in mind with autonomy. And whether what distinguishes it from knowledge would be a more, let's say, practical component in addition to the purely epistemic one, like involving some kind of skill or know-how or something that goes beyond the purely epistemic concept of knowledge.
That's a great question. And the paper that we've published talks about this distinction a bit. And it was taken, it's a hierarchy that is published, but it's come from, I can't remember the name. It's, I would have to look the paper up. I can tell you about it afterwards. Apologies to the recording and to Belle for not remembering. But it's a paper that was published a long time ago, like decades ago, and it hasn't really kind of come into this literature, at least so far as we know. Although Neil Manson might have talked about it in his work. But so it's this kind of hierarchy, and then I guess we are thinking about wisdom as kind of side by side with our conception of autonomy, like this kind of more idealized notion of autonomy. And if you have knowledge, data is just data. Data is what the test spits out. Information is kind of the information from the test made meaningful, as in interpreted. Sometimes if you think about it in a clinical way, it would be what goes into a report. And then knowledge is sense making about the knowledge, so kind of working out what it means. And then wisdom would be, I've made a decision about that knowledge, or I can sit with that knowledge in a way that works for me and my values. Now, obviously, the distinction between those four things is not going to be necessarily bright. They will probably overlap with each other a bit. But Belle has a chapter of her thesis where she writes about this in a bit more detail. But I'll find the reference for you.
That's really interesting, because I never encountered this concept of wisdom anywhere in the debate or practice.
It might be something that we've added as an extra on top. So we sometimes we have so many discussions about this that we sometimes end up thinking, have we come up with this or did someone else? And we also, in one of our commentaries on the paper, we came up with a term that we called epistemic fatigue. And it was this idea of people that you get exhausted by having so much information thrown at you that you actually end up not really able to make a good decision. And I'm sure that Belle came up with this term, and she's sure that I came up with this term. And so, but we liked it, so we're using it. And so, I would have to go back and read the relevant chapter of Belle's thesis. So I feel like I'm completely missing that answer to the question, but there is a hierarchy, and either we've applied it as it's published or we've added the wisdom on top. But the wisdom is really trying to get at what we're talking about with autonomy.
I might add this from communication theory, actually. So not necessarily. I will also curious this relationship with autonomy. But I mean, it is a very standard pyramid that you see written as always.
Yeah, okay,
So there's a lot of literature around it.
yeah. So we adopted some of
Yeah.
that in the work that we did.
Maybe this remark that I had at the beginning actually was connected to this idea of the components of autonomy. I mean, it's more a comment than a question, but I would be curious to hear your views about that. In an historical perspective, that this notion of autonomy that emphasizes the wisdom, the deliberative aspect of self-reflection, and you use this, and you also use the term moral perfectionism. I mean, it is perfectionist an account of the use of autonomy. And it's quite interesting because I think that autonomy is an historically very complex notion, and it's also a very tricky one to treat because it's somewhere in between deliberation and freedom to act. And historically, the pendulum has been swinging between these two extremes. But I mean, there is a sense in which in modern times, autonomy has been understood very much as freedom. I mean, it has its roots in religious freedom, in the Protestant uprising against the Catholic Church, and so it was autonomy understood in line with some Hellenistic understanding of autonomy as a feature of collective entities, not individuals. And then, I mean, in moral philosophy, autonomy became, let's say, the word that with Kant designated this idea of morality that is no longer a form of obedience, which has very much to do with the history of religious conflicts in Europe. So this idea that acting ethically is not obeyed. In this, you become normative. The individual becomes the settler of the norm, autonomous. And in a curious way, this perfectionist understanding of autonomy is like making good use of the choices that you have, is very much in line with the previous Hellenistic understanding of prohairesis in Aristotle, basically, and in the Stoics. So we are going back full circle to the origin of the term, and I was just wondering if we're losing sight of the freedom aspect of autonomy. I mean, I know that this might exceed the paper that you're going to publish, but anyway, it's published. So, but the idea that the freedom component of autonomy, the idea that autonomy is exercised when you are free to exercise it, when you are not constrained, when you have the right to exercise. For example, in abortion, you have the right to test, but you also have the actual right to terminate pregnancy.
Yeah.
And I was just wondering if you could maybe offer some reflection on this historical ramification of autonomy, whereby we are now emphasizing the deliberative aspect, maybe at the expenses of the freedom to choose. Yes, that was, you know, the notion, the Kantian notion of well, I mean, let's not go there, but let's say the Enlightenment notion of individual freedoms. I was just wondering if you had anything to.
Yeah, to be honest, I probably don't, because I'd say two reasons. One is it's not really part of the thesis and it's beyond the scope of this project. But so what I can say is that in her thesis, Belle has a chapter where she situates autonomy in the history of autonomy. Obviously can't cover every single thing that's been written ever, but Kate, her other supervisor, knows a lot about Aristotelian theory. She's a virtue theorist, and so has been able to give excellent guidance in that regard. And so she has a chapter both on autonomy and its history and context and how we got to where we got, And then she also has a separate chapter on reproductive autonomy, kind of doing a taxonomy, talking and comparing all the different terminology and how we got to where we got with that as well, before she even gets into the things that she wishes to advance about how we should change it. So I think we probably don't engage with the question in the way that you framed it, but what we've attempted to do at least is demonstrate understanding of how we got to where we got. Yeah.
I guess you have to circulate the thesis along with.
Yes. Belle will be delighted to hear that.
We'll get her to do an online one.
Yes, yeah, she could give, a 45-minute presentation just on her argument, I'm sure.
That would be cool.
Yeah, yeah, all right. We will, Belle, it's on the recording, so you're hired.
Great. Any final points before we wrap it up?
I have more of a theoretical question that, how do you think the stance of the parents would change if, like genetic editing would become more advanced and you could actually do more about the things you find out about?
Yeah. Well, if what they told us in the dialogue groups about prenatal testing extend to gene editing, I would say they would want to know how much it would cost. They would want to know what the risks of the actual editing process are. But other than that, I would think they would be quite enthusiastic about it. And they would be keen to have a so-called healthy child. And they would be keen to talk to other parents about their experience and keen to gain knowledge from others. They would also be really keen to access good quality information about it. I think they would also be keen to know what the process had gone through in order to become something that could be offered. Yeah. But we didn't specifically talk to them about modification technology. We kept it pretty tightly focused on testing rather than in intervention. We sort of presented interventions such as prenatal testing or PGT, just the kind of standard things that people are currently able to obtain. I should say a context in Australia is that PGT has hardly any public funding as well. So it's actually quite hard to have PGT in Australia at the moment. Relatively straightforward to have prenatal testing if that's what you wish to have. Yeah, but I think we as academics quite often worry that parents are going to think we are discriminatory or stigmatizing in our work, but I actually think parents are perhaps more permissive even than we are, I think. And it's really interesting to ask why that is. And it might be because they genuinely are, or it might be because we live in a society that actually doesn't make disability or difference very visible, tends to frame it in a fairly negative way. And we can ask ourselves questions about what, if anything, we should do about that.
I think it's time to wrap up, but thank you very, very much.
Thank you.